would like to thank the organizing committee for the invitation to come here and talk to this very nice meeting, and specifically to Savas Frankos, who called me and asked me to give a talk on thyroid ultrasound. Now, ultrasound provides accurate and reliable information regarding the position, size of solitary or multiple nodules. The ultrasound characteristics that we care about is the echogenicity, composition, vascularization, and the presence of calcifications. Now, ultrasound offers guidance for FNA of nodules and cysts, and ultrasound is very sensitive in identifying and staging cervical lymph node metastases from thyroid carcinoma. Ultrasound is also highly accurate for the detection of parathyroid tumors. This is an ultrasound transverse image of a normal thyroid gland. We can see the left lobe, the right lobe, the trachea in the middle, isthmus, the strap muscles, the carotids, and the esophagus. Ultrasound has limitations, especially in patients who are obese, who have a short neck, in patients who have a large thyroid mass or multiple nodules. If the ultrasonographer lacks proficiency in doing thyroid ultrasound imaging. However, the main limitation of thyroid ultrasound imaging is that its results do not correlate well with histopathology. And it's mandatory that the clinician uses information always in combination with clinical data. So whoever performs the ultrasound, either a clinician or radiologist, has to have the necessary clinical knowledge to be able to comprehend what he's seeing and correctly interpret the results. So more commonly, ultrasound is being performed by the endocrinologist, thyroidologist in the clinical practice office. Ultrasound may detect single or multiple nodules, and we know that malignant nodules can often coexist with benign ones, and papillary carcinoma is multifocal. A thyroid nodule is a distinct lesion within the thyroid gland, distinguished because it has a different echogenicity compared to the adjacent parenchyma. And we know that palpable nodules are present in up to 7%, maybe more of the population, but ultrasound examination in some studies can detect nodules in up to 68% of the population. Now, in multinodular goiters, what we have is multiple hyperechoic, isoechoic, or hyperechoic areas in combination with complex cystic colloid lesions. It's important here because the risk of malignancy in a thyroid with multiple nodules is comparable to the one with a solitary nodule. In other words, if you have one nodule, the risk of cancer is the same as if you have many nodules. So prioritization of the significant nodules and which ones to subject to FNA is dependent on the skills of who is doing the ultrasound. In some cases, radionuclide imaging can be used to determine the areas to be biopsied. This is an ultrasound transverse image of a multinodular goiter with confluent nodules. Now, ultrasonography is extremely helpful in assessing cancer risk, and it should be performed in all patients with suspected nodules. Ultrasonographic evaluation should be followed by FNA when it's indicated. The features that we record is whether the nodule is solitary or multiple, the size as 3 orthogonal dimensions, the nodule composition, the echogenicity, the presence of calcifications, shapes and margins, and vascularity. And I'll go over in more detail later on in my talk. The European Thyroid Association issued clinical practice guidelines in 2006 that suggested that all nodules above a centimeter that are non-functioning should be evaluated by FNA. Nodules that are less than a centimeter but have suspicious characteristics should be investigated. And suspicious characteristics are hyperechogenicity, irregular margins, microcalcifications, intranodular vascularity, and regional lymphadenopathy. The American Association of Clinical Endocrinologists and the European Thyroid Association also issued guidelines in 2010 that also suggested that nodules less than a centimeter with suspicious history or suspicious findings should be FNA'd. They also provide this diagram that stresses that if you have some suspicious characteristics, the indication for FNA biopsy grows stronger. One question that often comes up is whether we should do biopsies in nodules less than 10 millimeters. And what these guidelines say is that malignant involvement is not less frequent in nodules that are smaller than 10 millimeters. Thus, an arbitrary diameter cutoff for cancer risk is not justified, and suspicious lesions smaller than 10 millimeters should be assessed with FNA. Now, the new American guidelines by the American Thyroid Association that just came out place thyroid neck sonography central in the evaluation of thyroid nodules, whereas nodules with a high suspicion pattern or intermediate suspicion pattern, they should be FNA'd if they're above a centimeter. Nodules that have a low suspicion pattern, they should be FNA'd if they're above 1.5 centimeters. Nodules that are very low suspicion should be biopsied if they're above 2 centimeters, and nodules that appear benign should not be biopsied at all. And they also provide these nice images, ultrasound images, that help the clinician determine whether the nodule has benign characteristics, suspicious characteristics, and decide whether he or she should biopsy. They also talk about the issue of biopsying nodules less than 10 millimeters. And what they specifically state is that if a sub-centimeter nodule has no evidence of extrathyroidal extension, or if there are no sonographically suspicious lymph nodes, then you can follow up closely by ultrasound, even if you know that this could be cancer by ultrasound. Now, if the patient wants, if there is any preference, or if the patient's age suggests, you could pursue FNA in these small nodules. I will now move on to discuss the ultrasound characteristics that we record. First, nodule composition. Nodules could be solid, complex, or purely cystic. The more the solid portion of the nodule, the greater the risk of malignancy. And completely cystic nodules are rare, as high-resolution ultrasound will exhibit small solid elements in the nodule. Solid nodules have a high risk of malignancy, while complex nodules with a mostly fluid component, they tend to be benign. This is an image of a complex isthmic nodule with a solid element. Echogenicity is based on the nodule's ability to transmit or reflect the ultrasound wave. And this is compared to the parenchymal echogenicity of the thyroid gland or to the surrounding neck muscles. Hypoechoic nodules have less echogenicity compared to the thyroid parenchyma, whereas hyperechoic nodules are more echogenic. Isoechoic nodules have the same ultrasound characteristics as normal thyroid tissue. This is a longitudinal image showing a hypoechoic nodule. And this is a right lobe hypoechoic papillary carcinoma. Now, isoechoic nodules are identified due to the presence of halo, that's a peripheral sonolucent rim of decreased echogenicity. A halo can be thin, thick, complete, or incomplete, and this is important. If the halo is thick, absent, or incomplete, this could be an indicator of malignancy. This is a longitudinal ultrasound image showing an isoechoic nodule with a thin halo. Now, calcifications are extremely important. The reflective echogenic foci that cause ultrasound attenuation and appear as bright spots within or around the nodule, or can be found dispersed in the thyroid parenchyma. We divide calcifications to micro, coarse, or peripheral calcifications. Now, calcifications raise suspicion for malignancy, but the type of calcification and where they are provide more important information. Now, microcalcifications are 1 millimeter or less, round crystalline calcific deposits, most often representing samoma bodies. And this is extremely important, what I will say now. Amongst nodule characteristics identified with ultrasound, microcalcification provide the strongest indication of malignancy with a high positive predictive value. Microcalcifications have been described in both differentiated and undifferentiated thyroid carcinoma, but we could also see them in benign follicular nodules and in autoimmune thyroiditis. Now, the presence of microcalcifications in thyroid even without the presence of a definitive nodule, also increases the risk of malignancy, and it should be evaluated further. Microcalcifications now are dystrophic areas and tissue necrosis and can be found also in malignant and benign nodules. They're usually larger than 1 millimeter. Macrocalcifications can often coexist with microcalcifications in papillary carcinoma. Enlarged amorphous coarse calcifications are also prevalent in medullary carcinoma or metastatic cervical nodes from medullary carcinoma. Now, peripheral calcifications surround the nodule like an eggshell, and this is considered to be a benign characteristic. Now, if we have penetration of this rim calcification, the clinician should be worried, as this could indicate aggressive behavior or invasion by the cancer. This is a longitudinal image showing coarse calcifications, showing acoustic shadowing in a patient with Graves' disease. This is a longitudinal image showing a small nodule with eggshell calcifications. Now, the shape of a nodule is characterized as ovoid to round, taller than wide, or irregular. There's a high specificity and positive predictive value for malignancy when the nodule is taller than wide. Nodule margins are characterized as smooth, spiculated, microlobulated, or ill-defined. And the thyroid nodule is considered to be ill-defined when more than 50% of its border is not clearly marked. Ill-defined margins point to invasion of the surrounding thyroid and could signify an aggressive cancer. This is a transverse image of papillary carcinoma showing a solid hyperechoic nodule with microlobulated margins and an AT ratio above 1. Vascularity can be assessed with color flow imaging and power Doppler. We categorize color flow as type 1, where there's no blood flow, type 2, when there's perinodular flow, and type 3, when there's intranodular blood flow as well as perinodular blood flow. It's not specific, but thyroid cancers could have internal hypervascularization, whereas benign nodules may have only peripheral vascularization. And data obtained from color Doppler imaging should always be used in combination with other suspicious ultrasound features. This is a hyperechoic nodule with peripheral vascularity. This is from a study that we've recently published here in Cyprus that showed that the characteristics I mentioned earlier, the echogenicity, margin irregularity, composition, and calcifications are statistically correlated with suspicious thyroid cytology, whereas vascularity or size of the nodule is not correlated. And I have to emphasize that even with ultrasound, 69% of benign nodules will have at least one suspicious finding of papillary thyroid cancer, and frequently papillary cancers will have non-suspicious features. In other words, you should use the information from ultrasound extremely carefully. I will now move on to some thyroid pathologies. Hashimoto's thyroiditis, where by ultrasound the gland appears enlarged and diffusely heterogeneous. We have several hyperechoic areas or inflammatory nodules. Multiple tiny cystic lesions may also be seen, providing the characteristic Swiss cheese appearance. The gland has a lobulated shape with an enlarged isthmus, except in the case of a chronic form where the gland could be small, atrophic, and fibrotic. We could see coarse calcifications. We often see regional cervical and paratracheal benign lymphadenopathy, mostly in the initial stages, and vascularity can be normal or increased, similar to Graves' disease. This is a longitudinal image in a patient with Hashimoto's, showing an enlarged gland with the typical heterogeneous echotexture and the fibrous linear septations. Another transverse image in a patient with Hashimoto, showing the small micronodules, the hyperechoic nodules, giving us a Swiss cheese appearance. The main difficulty in examining Hashimoto's thyroids is to differentiate between the inflammatory pseudonodules and the true nodules that can be either benign or malignant, papillary carcinoma or lymphoma. In doubt or in the presence of calcification or other ultrasound characteristics, the physician should proceed to FNA in order to rule out malignancy. If there's associated cervical lymphadenopathy, the suspicion for lymphoma increases. This is a transverse image showing a small hyperechoic nodule in a patient with Hashimoto's. And this is a longitudinal image on a patient with Graves' disease showing markedly increased vascularity, the typical thyroid inferno by power Doppler. This is from the study that we've performed here in Cyprus, I mentioned earlier, showing that in nodules in patients with Graves' disease, there's a higher percentage of suspicious thyroid cytology. And this is in full agreement with the study performed by Savas Frankos. It was recently published in his cohort, showing that in about 41.9% of his thyroid cancer patients were thyroid antibody positive. I will now move on to thyroid carcinomas. Papillary carcinoma most often appears as solid and hypercoic, up to 70–90%, because of the presence of minimal colloid in the nodule. Calcifications may or may not be present, but the presence of punctuate microcalcification is a particularly identifiable characteristic of papillary carcinoma. You could also see coarse or peripheral calcifications. It's often multifocal. The nodule margins are irregular and ill-defined in most tumors. There could be chaotic or irregular hypervascularity, but could not be. In rare cases, we could see papillary carcinoma as an isoechoic or even hyperechoic nodule, or even with complex composition that's considered to be benign characteristic. Associated metastatic cervical lymphadenopathy is often present, and it should be carefully recorded. This is a transverse ultrasound image of papillary carcinoma showing a solid hypercoic nodule with irregular margins and microcalcifications. Another longitudinal image of papillary carcinoma with irregular margins and the microcalcifications. Now, cervical lymph node examination should always follow a thyroid examination, even if no thyroid nodule is identified, as there are rare cases, and we've seen a few, of aggressive metastatic thyroid microcarcinomas. In other words, you find nothing in the thyroid, but there are metastatic lymph nodes. The ultrasound characteristics of medullary carcinoma are similar to those seen in papillary carcinoma. Those nodules are irregularly shaped with either well-defined or spiculated ill-defined margins. They're predominantly solid with marked hypercogenicity, often with an irregular halo or complete absence of halo. Calcifications are most often present and appear as dense echogenic foci because of amyloid deposition and subsequent calcifications. In medullary cancer, there's a higher tendency for coarse calcifications. In familial medullary carcinoma, the tumors are multifocal and bilateral often. And we often see the associated metastatic cervical lymphadenopathy. This is a longitudinal ultrasound image of medullary carcinoma showing a hypercoic nodule with calcifications. Anaplastic carcinoma, rare, presents as a diffuse enlarging irregular mass. It's hypercoic with ill-defined margins, calcifications, and large areas of necrosis, with invasion of the gland capsule and infiltration of the adjacent vascular structure and muscles, and there's dense amorphous calcification and calcified masses. Now, follicular lesions, difficult to evaluate on ultrasound. Follicular lesion implies either follicular adenoma or carcinoma, as it's not possible to differentiate between the two with either ultrasound imaging or FNA. Follicular lesions are predominantly oval, solid, and homogeneous, but we could see them as isoechoic, hyperechoic, or hypercoic. If they're heterogeneous in echotexture, this could raise suspicion for malignancy. Calcifications can be seen. They have well-defined margins and regular. Follicular lesions often have hypercoic halo because of perinodular vascularity, but we could also see intranodular hypervascularization. If these nodules are enlarged, they have a larger size, if there's absence of halo, if they're hypercoic, and if we do not see any cystic changes, this could favor follicular carcinoma diagnosis, although it's extremely difficult to say whether whether a nodule that appears to be follicular lesion could be carcinoma. Now, Hürther cell lesions present similar to follicular lesions. These nodules are commonly solid, but can be hypercoic, isoechoic, or hyperechoic, or with heterogeneous appearance. They could have a halo, calcifications rarely seen, and these are usually hypervascularized and well-vascularized nodules. This is a longitudinal image showing a solid, homogeneous, oval, isoechoic nodule. This is a benign follicular lesion. Another transverse image of a benign follicular lesion, transverse image showing a solid oval nodule with some dot microcalcifications. Now, malignant thyroid lymphoma can present either as a primary tumor or a secondary tumor, part of systemic lymphoma. We could see this as a solid focal mass or diffuse large lesion. Lymphomas are mainly hypercoic, but in some cases they present with heterogeneous echogenicity and with areas of cystic necrosis. Ultrasound features of Hashimoto's are often present with an inhomogeneous gland with fibrous strands, and a large, rounded, irregular cervical lymph nodes are often present. I'll move on to discuss about ultrasound of the neck lymph nodes. Ultrasound of the neck and the lymph nodes is central in preoperative staging and surgery planning. This is from the European guidelines in 2006 that strongly suggest that any surgery must be preceded by an ultrasonographic evaluation of the lymph node chains. This is from the new American guidelines that say that thyroid sonography with survey of the cervical lymph nodes should be performed in all patients with known or suspected thyroid nodule. And the recommendations are that all patients that plan to undergo thyroidectomy for malignant or suspicious cytology, they should have a preoperative neck ultrasound for cervical, central, and especially lateral neck compartments. Now, ultrasound-guided FNA of the sonographically suspicious lymph nodes above 8 or 10 millimeters in the smallest diameter should be performed to confirm malignancy only if this would change management. And the addition of the thyroglobulin washout, and I'll talk more about this in my next slides, in the evaluation of suspicious lymph nodes is appropriate in only selected patients because the interpretation may be difficult in patients with intact thyroid glands. Neck lymph nodes, we divide them in 7 levels. Level 1, submandibular. Level 2, 3, 4, upper, mid, lower jugular. Level 5, posterior truncal. Level 6, pretracheal and paratracheal. Level 7, anterior mediastinum and supraclavicular. And when we examine the lymph nodes, we examine the size of the lymph node, the shape, and we evaluate for the echogenic hilum, the level of the lymph node echogenicity, the presence of necrosis, whether there's extracapsular spread and calcifications. This is an image of a normal cervical lymph node with the typical echogenic healthy hilum. Now, normal lymph nodes are well defined and oval or bean-shaped. They could be hypoechoic or isoechoic compared to the normal thyroid tissue. We describe the vascular pattern as hilar, peripheral, mixed, or avascular. And there are specific criteria for metastatic lymph nodes, such as hyperechoic or hypoechoic, absence of hilar line, inhomogeneous pattern, cystic, whether there are intranodal calcifications in the lymph nodes, whether they're diffusely hypervascular, whether they're enlarged, they have a round shape, and the APT ratio above 0.7. I have to state here, though, that none of the above is highly specific if taken alone. These findings should be used in summation. This is a transfer image of a metastatic rounded lymph node in the right lateral neck from papillary carcinoma. And this is a longitudinal image of metastatic papillary carcinoma lymph node without any hilar line and microcalcification. This is a transverse image showing a right paratracheal metastatic node with calcifications. Now, ultrasound imaging is also very important for follow-up after the initial treatment. As the European guidelines suggested in 2006, the physical examination is not very sensitive for the detection of persistent or recurrent disease in the neck, and neck ultrasound for assessing lymph node chains as well as the thyroid bed should be performed. The specificity of the neck ultrasound is improved if we study the characteristics and also if we do ultrasound-guided FNA cytology and thyroglobulin measurement in the aspirate fluid. Now, in addition to imaging the cervical lymph node, the ultrasonographer should pay particular attention to image the postoperative thyroid bed. Any findings such as residual thyroid tissue, scar, fibrotic changes, or sutural granulomas should be clearly marked. Cystic lesions, solid, hypoechoic, irregular paratracheal lymph nodes, areas with increased vascularity or calcifications should raise suspicion for thyroid cancer recurrence. I'll move on to some case examples. This is a 44-year-old male with right lobe suspicious papillary carcinoma. This is a transverse image, irregular nodule with calcifications. When we look carefully, this is a paratracheal irregular lesion with calcifications. And lateral neck, rounded, solid, suspicious nodes. This is a 31-year-old female with Graves' disease who had a small suspicious nodule and some right cervical nodes. This is a small 9.9 millimeter irregular nodule with some tiny calcifications. some smaller hyperechoic micronodules in the left lobe, and when we look carefully, some hyperechoic nodules in the right mid-upper jugular chain. Those proved to be metastatic nodes from papillary carcinoma. This is a 36-year-old female with papillary carcinoma who underwent right lymph node dissection, and she has a small, persistent, suspicious lymph node that we found after some difficulty because of these tiny microcalcifications in the node. This is a 34-year-old female who underwent thyroidectomy for multifocal papillary carcinoma, and the ultrasound of the neck showed suspicious thyroid bed lesions. These are the lesions, irregular, hyperechoic with microcalcifications, and the left cystic paratracheal irregular lesion. This is a 54-year-old female who presented to us because she felt a lump in the neck. She had a history of left papillary carcinoma 31 years ago, and she underwent only left lobectomy. She had this irregular left lobe solid lesion with irregular vascularity and a solid, well-defined, irregular, suspicious nodule with calcifications. She underwent surgery, and she had a tall cell variant papillary carcinoma in the right lobe and a classical variant in the left lobe. This is a 28-year-old male with papillary carcinoma who underwent thyroidectomy 11 months ago before we saw him. He presented with negative whole body scan and an elevated thyroglobulin. Imaging of the lateral neck showed normal, healthy-looking lymph nodes. This is right before I showed left. But when we looked carefully in the midline neck, we saw a thyroglossal duct papillary carcinoma that was successfully resected. Now, ultrasound-guided FNA for suspicious lymph nodes is performed when indicated. However, as the lymph node cytology is frequently negative, absence of malignant epithelial cells, we often aspirate only blood, thyroglobulin measurement from the needle washout fluid should be performed. And this is a very simple procedure where we involve washing the needle with saline solution and then measuring thyroglobulin levels. What we basically do is put the material on the slides, and what's left in the needle we wash with 1 ml normal saline. We put the material in a red hot tube and we send to the laboratory for measurement of thyroglobulin. And this is from a study by Savas Frankos, myself, and Nikos Katodridis that showed that the positive FNAB thyroglobulin after ultrasound guidance of suspicious neck lesions is 100% sensitive in identifying metastatic disease in patients with well-differentiated thyroid carcinoma. And FNAB TG is superior to FNAB cytology, and it should always be performed when investigating suspicious neck lesions and lymph nodes. Now, when a highly selective neck dissection is planned for either primary treatment or recurrence of differentiated thyroid cancer, the exact location of nodal disease or abnormality is of paramount importance to avoid unnecessary tissue handling and associated surgical time and morbidity. A simple schematic drawing allows for a more thorough surgical clearance of pathology while minimizing unnecessary dissection. In other words, a picture tells 1,000 words, and this is what we do. We put our suspicious findings in a diagram, and we annotate where we do the biopsy and our findings to help the surgeon do its work. Just a few slides on parathyroid lesions, not to be confused with metastatic lymph nodes. This is an inferior parathyroid adenoma, longitudinal image showing an adenoma inferior to the right pole. And this is a transverse image of a left superior parathyroid adenoma with a polar artery. These are the main references I used for this presentation. Conclusions: thyroid ultrasound provides accurate and reliable information regarding thyroid nodule characteristics and offers guidance for FNA. Thyroid neck ultrasound lymph node mapping is very sensitive in identifying and staging cervical lymph node metastases from thyroid carcinoma, and it's essential for all patients undergoing thyroidectomy. And thyroid neck ultrasound lymph node mapping is an extremely useful imaging modality in the post-surgical management of thyroid carcinoma. Thank you.